Okay, folks, thank you for coming to Cancer Center Grand Rounds. Today is two announcements I want to make. First is next week, okay, and talk about the range of what these next two rounds will be like. Next week's presentation will be the Calabresi Lecture, which will be given by Margaret Hamburg, who is the Commissioner of the FDA. A terrific presentation. I encourage all of you to get here early. I expect pretty much every seat to be taken, but we look forward to hearing Dr. Hamburg's presentation about where things stand with the FDA and its role in approval of drugs and agents and devices and laboratory tests. Dr. Morrow is eagerly interested in finding out what happens to lab-developed tests in the future. So that's next week. And that's one part of the equation, is what do the regulatory agencies think about what we do. The other part of the equation is what do payers think about what we do. And today we have a wonderful opportunity to learn from a person who is an expert in the field of where oncology payment structures may be going to optimize value. And I'd like to introduce Karen Adelson to introduce our speaker. Karen is our Chief Quality Officer of the Smilow Cancer Hospital.
So I'm really excited to introduce you all to Jennifer Malin. She's the Medical Director for Oncology Care Management at WellPoint. WellPoint is the parent company for all of the Blue Cross subsidiaries, probably our second most common payer. And in this role, she provides clinical leadership for all aspects of the delivery of care for WellPoint's members with cancer. She went to Harvard University for her undergraduate work and then received her medical degree and doctorate in public health from UCLA and health outcomes. She's board certified in internal medicine and oncology and is still an associate professor at the UCLA David Geffen School of Medicine. She's authored more than 70 peer review articles and is widely recognized for her research in the quality of cancer care. She's on a number of national committees, including ASCO's Quality of Care Committee, the COPE Leadership Group and Primary Palliative Care Task Force, and the NQF's Cancer Endorsement Maintenance Project Steering Committee. She's on the editorial board of numerous publications, including the Journal of Clinical Oncology and the Journal of Oncology Practice, and is a reviewer for the JNCI Cancer, Annals of Internal Medicine, JOP, and JCO. Since starting at WellPoint, she's maintained her clinical practice by volunteering at the Veterans Affairs of Greater Los Angeles. I first got to know her work for her headlining role at ASCO Quality every year. Joe Jacobson, who runs quality at Dana-Farber, once told me that he thinks Dr. Malin is the smartest voice in cancer quality today. I'm delighted that she accepted our invitation to come to Yale, and I hope her talk today, Realigning Reimbursement Policies for Quality and Value in Cancer Care, will challenge us to think about how we provide care and stimulate a lot of discussion in the weeks and months to come. Thank you.
Thank you for that introduction. I hope I halfway live up to it. Well, welcome and thank you for inviting me to talk today. Please feel free to kind of wave your hand and jump in with questions or comments. I'd like to keep this as interactive as possible. So I'm going to just start with, the concept of value, just kind of in the background, and then talk about some of the components of value. But there's a lot of discussion about value in healthcare today. And Professor Porter at the Harvard Business School has written about it, and I think he's come up with a relatively simple definition, which is outcomes over cost. And we can think about outcomes both in terms of our patient outcomes, but I think the way we achieve those outcomes is, I think, largely what we think about when we think about quality of care, is how do we deliver better outcomes. And the better we can do it achieving outcomes and quality at a lower cost, the more value we're able to create. So let's start by just talking about quality. And this is really what drew me into this field initially, is just I was amazed that when someone would call me up and want to find an oncologist or any physician, that there was really no way of knowing who the good physicians were, where to send someone for care. we all had sort of our networks, and we would rely, if it was in a different town, you'd contact a friend. And for the most part, that's still the way today, is that if someone, at WellPoint, I often will get phone calls from around the country, from different people in the company, when someone gets diagnosed with cancer, thinking as the medical director for oncology, I will know exactly where to send them. And it's a challenge. And for the most part, patients in the U.S. have access to the latest technology, but we still see that, study after study shows that 1 out of 3 patients doesn't get necessarily the most evidence-based care. They may not get the latest treatment. They may get the wrong dose. They may not get supportive care that would keep them out of the hospital. They may get supportive care that they don't need. There's just a lot of variation. I think kind of increasingly people are focusing on the hospitalizations of cancer patients. There's, for a long time, I think there was just kind of a slash and burn mentality, and you just accepted that people had to be hospitalized as a course of treatment. But it's been interesting to me in talking about this over the last couple of years that for patients and patient advocacy groups, they actually really see this as an important quality measure in terms of how often people are hospitalized on treatment. And this is one of the areas that oncology medical homes are trying to address. So there's a lot of interest in this. When we look at our data, about a quarter of patients are hospitalized during their chemotherapy, and 1 out of 4 of those hospitalizations is for a diagnosis with an ICD-9 code that you think might be preventable, like dehydration or pain. So clearly they're not all, but there definitely does seem to be some opportunity there, either through better supportive care or access to urgent care to decrease hospitalizations. And then finally, people receive a lot of tests and treatment that they don't need. This is an area that ASCO Choosing Wisely is focused on. But I think, people often tend to think about it in terms of, it's wasteful, it's cost that's the issue. But I would argue that in addition to putting people sometimes at risk of side effects, it also creates a care burden for them that they don't, that they're not getting benefit from. And I don't know if this is just an anecdote I heard recently, but I think it helps to drive this home. So a couple weeks ago, I was in Washington because we're launching a pilot program with several of our large employers to help transition cancer patients back to work. And so working with several different organizations, we've helped to develop an e-toolkit to help managers facilitate this process. And one of the speakers at this forum was from an organization called Cancer and Careers. And she told the story of one of their constituents, basically, who had gone through her treatment for colorectal cancer. Her employer had been very supportive. And then once she had completed treatment and she was having to go back every couple of months for scans, was when the employer said, this is just taking too much time away from work. I'm sorry, I'm going to have to let you go. And so, the question is just, who knows how often she was getting them? Was she really needing to be scanned that often? And, it creates, a burden of having to take time off for work. But in her case, it actually ended up then causing her to lose her job as well. So there's all these kind of additional effects that we don't usually think about when we're writing the order. So this is an area that the Institute of Medicine is focused on. I actually got my start in the field in 1999 when the Institute of Medicine issued their first report. And then 2013, last year, they came out with another report that really kind of mostly said not much has changed. I think, we know a lot more about the issues, but there's still no national quality reporting program with meaningful quality measures. And then the other area that the Institute of Medicine really focused on this time around, though, was the issue of affordability and the need to align reimbursement to reward affordable, patient-centered care. So these are some examples of some of the quality measures that have come out in the last 10 so years, 15 years, I guess. So this is from ASCO's COPI program. And so this is adherence to adjuvant therapy. And you can see for the different, it's breast and colon cancer over there on the right, and lung, as well as lung cancer. And I think the thing that's striking about this graph is just how high the adherence rates are. And so this is for practices participating in COPI. And you can see that across the board, it hasn't really changed much year over year. And, it's 90+ adherence to patients receiving adjuvant therapy. You never know exactly what the in situations like this, because they don't exclude, there's not that many exclusions to the denominator for comorbidity and for patient preference, so clearly wouldn't be 100%. So this is probably, about the right range. So then the question is, so are we just providing excellent care and we should all go home? There's nothing more to talk about. And, that could be one take. I think one issue, though, is I would argue that at this point this measure is meaningful. That we don't know from just did they get adjuvant therapy, we don't know did they get, for colon cancer, did they get FOLFOX? Did they get capecitabine alone? Did they get something else? For breast cancer, what regimen did they get? And then, were they given, a breast cancer regimen that doesn't require growth factor, but they still got Neulasta every cycle and had bone pain? So there's these are sort of very high-level quality measurement, but it doesn't really give us the kind of detail that we need in the end to be able to say, where should you go get your cancer care? Which is one of the issues that I'd like to be able to address. And then some of the other quality measures that COPE has really pioneered, which are more patient-centered measures, and you can see that there's huge variation in these across the board in terms of antiemetics being prescribed, dyspnea being addressed, and again, not much change over time. So this is kind of disheartening because over 10 years that these practices have been participating, and they're getting kind of the same results back and forth, but yet nothing changes. So clearly just measuring it isn't enough to change. So what's it going to take for practices to think that this is something important enough to focus resources on to try to improve their scores over time? And then this is another example of sort of the well-known variation in quality. And so this is variation in perioperative mortality and survival for cancer surgery. And it's the hazard of death so the hazard of dying at the hospitals with the lowest volume, so the lowest quintile of volume, compared with the highest quintile of volume. And you can see that basically, for liver cancer, I can't see so liver cancer, you're about twice as likely to die in the 30 days following surgery at a low volume hospital compared to a high volume hospital. So huge variation, and yet this is not something that we've really done anything about from a policy standpoint. And I think many of us in this room would probably know, well, gee, I want to go to a high volume hospital, a surgeon who does a lot of these things. But for most people in the country, they're completely unaware of this. And there are no real policies in place to try to address this and figure out, either what is it that the high volume places do better so that we can translate that to the lower volume places, or should we start to regionalize cancer surgery the way they've done in Canada? And then here's another example. So this is work done by Bruce Hillner and gets at the issue again of the care burden. So this is Medicare data, and it's imaging studies that are repeated. So the blue bar is a CT scan done less than 30 days before a PET CT, and the brown bars are a CT scan done less than 30 days after a PET CT. So you can see for most of these patients, at least half of them are getting a CT scan in the 30 days before, and a quarter of them are getting another imaging study within 30 days after. Now, usually when I show this to a room of oncologists, everyone says, oh, well, in staging, you get multiple tests. But this isn't staging. This is any time they got a PET CT. So the question is, how much re-imaging is happening? And it's not necessarily mean that the oncologist is ordering all these tests, right? It might be that, the surgeon orders one, the medical oncologist orders another, they go to the ER and they get a CT of the chest to make sure they don't have pneumonia or PE. So we don't really know from this data why it's happening, but we do see, a lot of repeat imaging, basically. And then this is from our data, and so this is the widespread variation that we see in the use of colony stimulating factors. So the tall bar in the middle is where most of the practices are. So most of the practices are using growth factors in between 15 and 24% of their patients on chemotherapy. But you can see the range is from less than 5% to more than 2/3. And you might say, well, this is probably because, the ones at the far end are all treating lymphoma, and there's, just huge variation in patient types. But actually, when we break this out and just look at breast cancer, the distribution becomes even broader. So there's just huge variation. So I'm not saying that I know what the right percent is, but it's just, clearly there's, a lot of variation going on with probably overuse and underuse. This is from a study that I did with some colleagues as part of the CANCORS consortium before I went to WellPoint. And so CANCORS was an NCI-sponsored study, population-based study, looking at patients with lung cancer and colorectal cancer. And we followed them over 5 years and surveyed their physicians and reviewed their medical records. And so there was a variety of different data sources. So this was from the physician survey, and you can see that, I think the good thing is that the blue bars say for most physicians, they didn't feel that these things were going to change their income much. But you still see that around, 20 to 30% of physicians said that administering growth factors or chemotherapy was directly tied to their income, essentially, that their income was tied to volume of those services. So this, again, sort of ASCO's choosing wisely, again, really just, all the different things that I've just shown you in terms of imaging, colony stimulating factors, have all shown up on ASCO's choosing wisely list as things that we should really probably not be doing, because there's not a lot of evidence for benefit, and it costs the system money and may cause harm. Now, I haven't seen any population-based studies yet on choosing wisely, but at least sort of anecdotally what I've heard from different people around the country and different payers is that the campaign hasn't really made much difference in the use of any of these things. So this is their other list. Let's see. So, what is it that drives the use of different therapies? And this is an issue of IMRT. So you can see this is the rapid uptake of IMRT around 2000. And, with an increased cost, and at the time, this was for prostate cancer, there wasn't any evidence that IMRT was going to be better than standard 3D conformal at the time, but there was very rapid uptake. And this is from the Wall Street Journal, and, it brought up the issue, it questioned, why was there this rapid uptake, and could it be profit motive? And it turned out that many urologists were actually buying shares in radiation oncology facilities, and what they would make on a typical surgery for prostate cancer was around $10,000. But by referring someone to IMRT, they would actually make substantially more than that and not actually have to perform the surgery. So it was kind of, win-win. So this, has been shown over time to be one of the things that largely drove the increased use of IMRT and still contributes to its overuse in places. A slightly different thing, I think generally probably a happier story, but we still see kind of another trend in rising cost, and that's in chemotherapy or cancer therapy drugs, not just chemotherapy. But this is from Peter Bach at Memorial Sloan Kettering, and the thing that's remarkable about this slide is the y-axis is actually a log scale. And so you can see that, in the 70s and 80s, most drugs were around, $100 a month. And, in the last few years, basically everything that's been approved by the FDA is $10,000 a month or more. And some of the new therapies, for me, the kind of therapy that really stands out as being kind of the major breakthrough in cancer care since I've been in practice is Gleevec. When I was a fellow, we treated most people with bone marrow transplant, and it was always this terrible decision about when do you transplant them, because they were usually asymptomatic with their disease, but once they went into a blast crisis, they really wouldn't survive. And, they had, depending on their age, a 40 to 60% chance of dying during the transplant, and they would live with graft versus host disease. So Gleevec really has changed that dramatically. And these people appear to be able to live out their natural life expectancy with Gleevec. That being said, if you look at the treatments approved by the FDA in 2012, only one extended survival by more than 6 months, 2 extended survival by only 4 to 6 weeks, and the average cost of treatment per month was $6,000. So the question is are we really driving innovation, true innovation, by the high costs? I mean, that's what the manufacturers will tell you, is that, well, we need these high prices because it costs us a lot, and if you somehow pay us less, or have any more rigorous process of assessing outcomes, clinical meaningfulness of outcomes like ASCO came up with, that the tap's just going to dry up and we're not going to be able to develop drugs. So that'll be something interesting to ask Dr. Hamburg next week, what she thinks. And there's a kind of I think a gut level feeling of sort of, can you put a price on delaying death? This is what the title says. So Provenge, I think, is around $120,000, something like that, $100,000, give or take, for a vaccine, for a therapy that interestingly seems to potentially prolong overall survival but has no impact on progression-free survival. So it's kind of the opposite of what we usually are contending with in oncology. But, this is, the question being asked, is it worth it, and how can you put a price tag on delaying death? So now I'm going to kind of shift gears a little bit and talk about, so why should we care about cost? So this slide here on the right is from the Annals of Family Medicine, the graph on the right, and it shows the point at which costs for healthcare for a typical family are going to equal half of the median family income. And you can see where we are as of last year. So the median family income in the United States has not risen much over the last few years. It's around $52,000. The cost for families' health care is $22,000. And I think this is the part that, we're often used to thinking about, well, healthcare is something that the payers are supposed to pay for. It's supposed to get paid for there. If someone's suffering with costs, it's because the payer put too much of a copay on it. But I just want to kind of have people think about it. So of the median family income, the employer's contributing an additional $13,000 on top of that instead of wages to pay for that person's health insurance. And then they're not, if they were contributing all $22,000, then, it would basically, the employer would be paying half of someone's salary as health insurance. So right now it's about, a quarter, give or take, 20%. But then the employee still has to contribute $5,500 to their premiums, and then their deductibles and copays are $3,600. So when we talk about healthcare being unsustainable, the cost going up being unsustainable, this is really what people are referring to. Now, one thing is, in the New York Times a couple of months ago, there was an article about how in most parts of the world, people spend about 50% of their income on food. In the United States, we spend less than 10% of our income on food. So part of this is a good thing, right? It shows that, we have more wealth, so we're able to spend more on healthcare. So that's a good thing. We're able to do that. But the challenge becomes, at what point are we spending so much on healthcare that we're not able to spend on things like education and other things? And association is not causation, but in California, UCLA, where I'm from, has actually been a number of times in the Dartmouth Atlas, the most expensive hospital in the country. It costs about, for CHF or other conditions there, it costs Medicare about twice what it does at the Mayo Clinic, with no improvement in outcomes. And what are the three things that our state budget goes to? Healthcare, education, and prisons, which we also spend too much money on. But, over the last, 5 years, basically the tuition at the University of California colleges has skyrocketed. The staff at all the university facilities is now furloughed for a week and a half a year. So, again, not causation, but it seems like, we have a limited pot of money, and, our state institutional hospitals are not necessarily thinking about how to provide value-based care, even compared to the academic peers around the country. So what about when we think about cancer care? So the chart on the left is where the revenue comes to for a typical oncology practice. And so 2/3 of the revenue comes from drugs, basically. This has often been referred to as the buy and bill model. And, I don't know that there's a single oncologist today who would design the system this way if we were designing it from scratch, but this is kind of what we inherited. The thing that is always kind of impressive to me is only 8% of the revenue to the practice comes from the E&M codes, which is what all of us as physicians think we went to medical school to do. So, the challenges, and I think, oncologists often get maligned in the press for, making all this profit off of drugs. But the reality is, for a typical practice, there are about 7 FTEs per physician that are needed to provide the care in that practice. So if we're trying to figure out how to have the practices be more cost conscious and spend less money on drugs, that's going to decrease their revenue, and they're not going to be able to provide care for the patients in the same way that they have been. The chart on the left shows this from the payer side. So this is where the dollars go from our health plans, and this is for all patients in active treatment. So it's not just people getting chemotherapy. It's anyone with cancer who's diagnosed and is getting either surgery, chemotherapy, radiation therapy, or any combination thereof. And you can see that on the payer side, 25% is going to chemotherapy and supportive care drugs. And then you saw that chart, with the exponential increase in costs of new therapies a couple slides ago. So you think about if the chemotherapy costs are going to keep growing at that rate, and the pie is not going to get that much bigger because we've kind of reached a ceiling at how much we can all afford to spend on our health care, that we either have to figure out a way to move things around or we're going to squeeze out the rest. So, and I personally worry about squeezing out is the physician, the clinical care, because that's when we talk about patient-centered care. I don't see how we get patient-centered care if we aren't able to pay for the people to actually sit there with the patient. And so as we're thinking about this, we've been thinking about how can we realign reimbursement so that it's value-based and patient-centered, but also where do we take the dollars from to shift it around? Because the pie is not getting any bigger, so there's no new pot of money coming that allows us to do this. So I'll talk a little bit about our program in a minute, but here's an example of 6 regimens for non-small cell lung cancer. And if you look at the variation in outcomes, so regimen, some of these have multiple studies, so where there's multiple randomized trials, what's represented here is the outcome from the best outcome reported in any of the randomized trials. So you can see it ranges from about 13 months, 10.4 months for treatment B to 13.4 months for treatment E. The confidence intervals are largely overlapping, however. And then you can see that there's some modest variation in adverse events. The nausea and vomiting risk varies somewhat, although that really just depends on whether you're giving carbo or cisplatin, and which people often interchange in these anyway. The neuropathy risk varies. And then the amount of grade 3 or 4 fatigue, which really means you kind of can't get out of bed in the day and spend most of your time in bed, varies quite a bit. The other thing that's really hard to figure out from any of our clinical trial published data is what the serious adverse events are from a patient perspective. The adverse events all get reported at an incident level, but you don't know whether someone the people who had dehydration, nausea and vomiting, and febrile neutropenia, whether that was 3 different events or all happened in the same patient. So it makes it really hard to kind of really compare what the impact of the toxicities is at the patient level. And very few studies report the hospitalization rates, which would give you some other sense of how toxic these regimens were. And then the last column over there, I think is something that we rarely look at as oncologists when we're doing decision-making with patients, but I would argue might be something really important. So if you look at regimen E, you can see that the deaths on treatment that were attributed to treatment is about 4% compared to 1%, give or take, with most of the others. And so the question would be, would someone take an increased risk of death for a month later on or not? I mean, is that a worthwhile risk? So here are those same regimens, and here's the variation in cost. So for 4 cycles, which is what you typically do for platinum upfront in non-small cell lung cancer for people who don't have an EGFR and ALK mutation, it ranges from $450 for 4 cycles for carbotaxol to $65,000 for 4 cycles for carbopemetrexed bevacizumab. So, and I would argue that those outcomes are really not that different. So the kind of leaders in developing pathways have been U.S. Oncology, and they started this in their program probably about 10 years ago. So this is their outcomes that they published a few years ago in non-small cell lung cancer. And I believe at the time, because this is from, the patients I think were treated in kind of the 2002 to 2005 timeframe, their standard pathway regimen was carbotaxol. But you can see that they basically had no difference in survival whether patients were treated on pathway or off pathway. But overall, there was a 30% decrease in overall costs, not just drug costs, for patients treated on pathway. So if we go back to what the Institute of Medicine is calling for and saying, we need to think about quality and affordability. And one of the things that I think is interesting about this figure from the Institute of Medicine is that if you look at the pink box on the right, it talks about quality measurement, including patient outcomes and cost. One of the things that I found interesting about this is I think it's the first time that I've seen quality and cost put together. Usually there's often this kind of implicit trade-off that if we're going to lower costs, we're going to have to lower quality. And I think the challenge really here that is the IOM is saying, we have to stop thinking about it that way. We have to think about how are we going to achieve both and stop thinking of them as a zero-sum game. And then the other piece in the middle here is where I look at this from a payer, which is how are we going to align payment to try to achieve improvement in these things. We've seen with, a decade of COPI, we're getting more and more practices participating, but it doesn't seem like it's really changing quality very much. We see that technology continues to get more expensive, some of it really improving survival, but other of it not, what Zeke Emanuel likes to call pseudo-innovations. So what are we going to do? So what we decided over the last couple of years and have just started implementing is a program that basically ties reimbursement to adherence to pathways. It also provides the framework for us over time to start to pay for performance for other quality measures. And so the practices participating in the program, if they select a regimen that's on pathway, are eligible to bill for an additional $350 per patient per month. So they still get to bill whatever they're billing for the drugs and the E&M codes. So, and it doesn't affect coverage decisions. So they can still select a regimen that's off pathway if they feel like that's the best thing for the patient. But if we can get them to move slowly towards pathway regimens, that it should overall lower the total cost of care and allow us to provide additional revenue to the practices to be able to provide that patient-centered care. The program, it's kind of as a side piece to decrease administrative burden. The way we're implementing this program also incorporates what has been our prior authorization process so that it's all in one place and it's much more automated so that hopefully it decreases the administrative burden for practices as well. And at least so far, we've launched this in the Midwest and Georgia, and so far that actually has come to pass from what we're told from those practices. So this has been something that people have asked us a lot, because if you're familiar with this space, you know that there are a lot of pathway companies out there. Some practices or institutions develop their own institutional pathways. And so we looked a lot at different vendors and trying to license pathways from different vendors. And one of the challenges we ran into was that we really wanted, just like our medical policies are available on the web, we wanted the transparency of having the pathways up there available for everyone to see. And these vendors' business model is basically that the pathways are their intellectual property, and you don't get to see them unless you pay the licensing fee. So, clearly the physicians in our network would be given access to them, but we wouldn't be able to put them up for everyone to see and to have kind of that level of transparency. The other thing is the vendors all have their own software systems that they use, and we wanted the system to be able to be integrated into our claims platform so that basically it would, allow everything to flow seamlessly, the bills to get paid, to know when to pay for the adherence and the authorization. And if we were using one of these external vendors, that wouldn't have been possible. So what ended up happening, and some people have criticized us for this, so I'm being very transparent about it, is that we decided that we were going to have to develop our pathways internally using a process similar to our P&T process. And so that means that we do the research internally, and then we have a group of external advisors who provide us input on whether or not the pathways are really going to provide appropriate options for 80% or so, 80 to 90% of patients. And so we have internal team of oncologists and pharmacists who start with the guidelines, review the evidence associated with each of the regimens in NCCN and ASCO guidelines, and summarize the clinical benefit, the side effects and toxicities, especially ones that lead to hospitalizations or may impact quality of life, the strength of the national guideline recommendations. So, like NCCN will have category 1 and 2A, and ASCO now has, I think they have a new thing now too, where it's like they're rating the evidence and the strength of the recommendation. So, looking at those, and then lastly, the cost. And then after summarizing, and I mean, the tables look fairly similar. I mean, it's been kind of simplified a little bit, but when you think of the tables that I showed you before, that's fairly similar to what the tables would look like then when we sit down with our advisors to talk about, well, what should be on pathway. And the goal essentially, so our goal is to have patients getting the most effective therapy, and then if there are multiple options available, have them get the most cost effective, and not have it be restrictive, that there's always an out for individual patient circumstances. So looking back at what I showed you before, here are the regimens out of those 6 that are on pathway. So it's interesting when I show this slide. So when I show this slide to non-lung cancer docs, they're like, why didn't you just put the first 2? And then, different folks, sometimes I would say the most interesting reaction I had was that I presented this slide at the Georgia ASCO meeting, ASCO Highlights meeting, and one of the oncologists in the audience got up and said, wow, there's such a difference in cost. That's amazing. I had no idea. So you mean if we stopped treating people, it would be this? And everyone was kind of looking around and nodding. And then someone from AmerisourceBergen, which is one of the big drug distributors, got up and gave this literally 10-minute impassioned plea to continue practicing oncology the way you have been. Someone finally had to drag him off. It was just interesting drama. I mean, he was so memorable that actually the pharma reps who were at the meeting came up to me afterwards and apologized. So I think, one of the values I think of doing this kind of thing is it really just generates conversation. And we can start to have dialogue about really what is the kind of meaningful outcome that's, worth, $60,000. I mean, are we making enough of a meaningful difference between carbopemetrexed and Bev and carbopaclitaxel to have it be worth $60,000 at average sales price? So, at hospitals like Yale, that's probably costing more like $200,000. And if you think that if the patient, depending if they just have Medicare, they'd be paying 20%. If they didn't have a Medicare supplement, that would be coming out of their pocket. So just kind of thinking about the different ramifications, starting to think of the big picture and what really is truly a meaningful outcome for patients. And I think the other thing, so ASCO's been doing different things to look at this as well, and I think, which will be very helpful, they're coming up with some sort of value rating to try to help, rate basically the relative benefit to the cost of therapies. But at least right now, they're envisioning it as that it would be something that an oncologist would sit down in front of a patient with. And I think the challenge for me with that is just that if I were to sit down with this table in front of patients, I think they would first of all say, well, why would you even suggest the $65,000 treatment if you didn't think it was better? There must be something here you're not telling me, because otherwise, why would you even talk about it? I mean, if you had two cars that were identical next to each other and one was a lot more expensive than the other, it would be a no-brainer. So if one's a lot more expensive, then what really is the difference? So maybe we're not capturing the real difference with the evidence, but then that's a problem for our evidence base. We need to make sure that it's really capturing, the quality of life benefit or something that's really a meaningful benefit to patients. So a little bit about the nuts and bolts of the program. So how do we pay for treatment planning? So basically recognizing that in today's world, we primarily pay for treatment planning care coordination through the margin on the drugs. The idea was, how do we start to just pay for that directly when someone's on a pathway? And so there's two new S codes that are actually, S0353 is for initial treatment planning and care coordination, and S0354 is for ongoing treatment planning care coordination. And when practices select a regimen on pathway, and they have to go through a portal to pick the regimen so that we know that they're on pathway, then they receive an authorization to bill this S code so that every month they can bill for the additional $350. So here just is sort of, so this is for the practice getting reimbursed at ASP plus 6%. So here is what the revenue is to the practice for those different regimens. So you can see for carbotaxol, basically the practice makes almost nothing on the drug margin. The green is just the CPT codes for chemotherapy administration. And at the far end, it's about $4,000 additional revenue to the practice for 4 cycles for the carbopemetrexed bevacizumab. So here's what happens with the S code. So, to my mind, when I see that, it certainly doesn't, in any case, overwhelm the most. The carbopemetrexed bevacizumab is still going to bring at least as much revenue to a practice, if not more, than any of the others. But it makes the difference in revenue to the practice, I think, smaller. Overall, there's less of a difference between choosing a less expensive regimen and a more expensive regimen. So this has been an interesting discussion as well, because some people have argued that the $350 is an inducement, and that you're inducing practices to not provide care. Which we clearly disagree with. But I think this slide supports our position that we've already been paying a lot of incentive to provide care that may be more expensive and not necessarily any better. And what this does is really diminish the differences in revenue stream to the practices between the most costly and the least costly alternatives. So we started the program in July in the central region in basically our Midwest states and Georgia. And in July we had pathways for breast, colorectal, and lung cancer. Since then, we've added pathways for lymphoma, myeloma, ovarian cancer, and pancreatic cancer. That was in September. In November, we're adding pathways for CNS tumors, melanoma, and advanced endocrine therapy for breast cancer. And then early next year, we'll add CML and prostate cancer. And then that sort of from a cost perspective gets us to kind of the largest portion of the cost. Each additional tumor type after that is kind of a very small percent. So we're going to be trying to think about what strategies, what prioritization from here on should be used to identify different tumor types. Some may be, providers may say that they really want an area. Some may be if there's particular tumor types that have issues with quality of care that have been documented where we think we can help to improve care. And then other things like, several people have mentioned renal cell cancer just because there's so many different therapy options there that it might be helpful to have some guidance on value. I think one of the interesting things is that, we think about, we talk about this from the issue of quality, value, and, being able to improve the value outcomes. But there really is a terrific opportunity to focus on quality and dissemination of data here. How am I doing time-wise? Okay. So one of the things when we were reviewing the literature for CNS tumors, it turns out that there's recent trials that show 12-year survival data now for low-grade gliomas with giving adjuvant chemotherapy, which is probably not something that most general oncologists would be aware of. I know I certainly hadn't really been paying attention to it. And so this, we've put those on pathway. So I think, that provides a nice opportunity kind of in addition to, NCCN and other guidelines out there that are trying to help disseminate innovation, disseminate new therapies, that this is something that there's, the chemotherapy's PCV, there's no drug company that would be out there marketing to people, you need to start using it in these patients. And so, it provides, I think, another opportunity to disseminate data. So just briefly on some of the logistics. So AIM Specialty Health is the organization that's operationalizing the program for us. They already do pre-authorization for us for radiology benefit management. And the way the process works is that a clinical request is made through a web portal. The treatment is, there's basic criteria that gets entered like stage and biomarkers. If the criteria match up with medical policy, then the authorization is issued just based on that data, and then it also determines whether it's on pathway or not. And then at the end, it prints out a report basically for the authorization and the pathway eligibility. So I'll just, a couple of screenshots. So this is like the screen of where the diagnosis and the drugs get entered. It's designed for non-clinical staff, not for physicians to use. This is the basic clinical information. So this is for a breast cancer patient. You can see that in this case, oncotype wasn't done, so it gets recorded as not reported. So the main thing for practices has been if they don't have an EHR where there's sort of a standard place that all this information is kept, it's for them to figure out in their workflow how they're going to make sure that that's in one place so that the non-clinical staff person can find it when they're entering the information. And then they get a list back of regimens. So the 4 on top are pathway regimens. And then the ones below would be all the ones that are NCCN. So it, even if there was a tumor type that didn't have pathways, it would still bring back all of the NCCN recommended regimens for the practice. So it does provide some basic level of decision support in that way. And we don't really expect, for the most part, that practices will change as their administrative staff is inputting the data. It's one of the reasons that we have the pathways up on the web. In general, I think most practices have been downloading them, reviewing them at kind of clinical meetings, and deciding, if it makes sense for their practice, how they incorporate them into their workflow. And then this is the summary report that comes out at the end. So you can see the Pegfeld-Graston required prior auth, so it says authorized. The other ones are just completed. And then down at the bottom, it gives the 2 S codes and the number of times that they can be billed. So fortunately, we were a little bit on pins and needles because we didn't want this to be overly burdensome. We've been working with a company called Evity, and in some of the states where Evity's gone in and done this by themselves with their sort of native product, there's been a lot of consternation and pushback. And maybe not in Connecticut, but in many Anthem states, we're like 30% of the patient volume. So if this wasn't going to work very well for the practices, we were really going to have a revolution on our hands. It was not going to be pretty. So we've been very gratified that we're told anyway it's taking about 2 to 3 minutes for the person to enter the data. And I've talked a lot about the website, but there's the website and includes all sorts of information in addition to the pathways. Anyone can download the pathways. There's an email if you have comments you want to send back. And then we do have the detailed worksheets with the evidence that I'm happy to share. We're still trying to figure out the best way to make them publicly available. If we were to just put them on the website, then all your patients could download them and come into the office visit, and you'd be sitting there facing that chart. So we weren't sure people would be too happy if we did that. So if you have any great ideas of a good way to sort of make those available, we're actively soliciting input on, because I think they are great, education pieces and, for discussion and thinking about, what's the best way for us to do things. But if you email me, I'm happy to share them with you. And that's it. Thank you.